And as one of the items we also have is a handout. I kind of condensed the medical decision-making table, so you'll be able to access that too. So welcome while we work through the Evaluation and Management Code Updates, Part 1. Just kind of a disclaimer that we always have to do for these, that it's current as, as current as it is today, but, tomorrow can always bring something new, it seems like. And so what we'll be covering today are the general guideline changes. I'll be discussing the inpatient and observation services, which kind of pairs nicely with the admit and discharge on the same day services. And then I'll be talking about the prolonged services. And tomorrow, Mickey gets to cover all of the other stuff that goes along with it. So in this section, we'll just cover some of the general guideline changes. And this is really not any specific guideline section. So just kind of as a reminder that these are based on E&M codes that used to have like the history and medical decision-making as the determining factor. So the kind of the high-level overview is that there are the changes to the hospital inpatient and observation care services codes, and we'll have some of the descriptions in some slides later. There are some changes to the consultation codes. This is also going to affect the emergency department codes, nursing facility, home and residence. So these are the kind of the other outpatient evaluation and management services. There's also the deletion of the hospital observation E&M codes, the 99217 through the 99220, because they've now combined those with the hospital inpatient visits and made them into the inpatient and observation care services. And so they, in streamlining the medical decision-making to the straightforward, low, moderate and such, they have deleted 2 of the consultation codes and then revised the other consultation codes, of course, because all of the codes are being revised to so that you can see the time in them and just with the terminology changes and fun. All right. And then the emergency department services, they are also being revised and have some revised guidelines, but these will not be time-based. There's a deletion of a nursing facility service E&M code, and then the other codes are all revised because they're now based on time. And then they've combined a lot of them with like the domiciliary and rest home or boarding home custodial care. Those are going to be deleted because they're going to add those to the other codes in the section. And so just kind of the more deletions and revisions. And there's a new prolonged services E&M CPT code. When the documentation for this was originally published, the E&M code was put in as a placeholder, was 9930X. The codes have been published now, so that has been replaced with the permanent CPT code of the 99418. All right. And also, if you're for the AHIMA and you have the CEU post-webinar Q&A, you might want to remember the 99418, just as a little hint. And so why is this? And so the CPT panel has really said what their impetus for this is to decrease the administrative burden of the documentation and the coding. And where they could, they tried to align CPT and CMS When we get into talking about the prolonged services time, you can see that CMS didn't do that, did not reciprocate, I guess you could say. But this should hopefully decrease the need for audits and also decrease the unnecessary documentation in the medical record. So not all of that extemporaneous information that, you had to get to make your levels. And so it's going to decrease the note bloat. And then also to ensure that the payment for evaluation and management is resource-based. And so there would be no direct goal for payment redistribution between specialties, because if you were a specialist trying to go by some of the guidelines, it was very difficult to hit, the 99214s and 215s, just because of the documentation guidelines that were followed. So this should remove some of that issue. So that should be helpful in that instance. All right, so for the general guideline changes, what I tried to do was just include the 2022 versus what's new for 2023. And I did include some things that were staying the same, just so we had access to some of that information while we're looking at it. All right, so similar to the outpatient office visits that have been operating under the guidelines where that exam is not required, the 2023 updates are going to expand that concept to the rest of the E&N codes that use that history, exam, and medical decision-making as part of the components. So that's really nice. So only a medically appropriate history or physical examination is performed when it's needed. And it used to be interesting that there was always a debate, well, you can't do an exam without putting your hands on the patient. And well, yes, you can. So this kind of takes that debate off the message boards, I guess. And so the extent of your history and exam is not going to be used as an element in the selection of the E&M. So it's going to be based on either the level of medical decision-making or the total time for the services performed on the date of the encounter. And so the concept of medical decision-making is not going to apply to the 99211, which we already knew. But now it's going to add the 99281 to that. And emergency department is going to be discussed tomorrow. But also another hint for the quiz, just remember that the MDM does not apply to those two codes. And then just kind of the nice thing about it is that only minimal updates were made to the medical decision-making table, specifically for the low levels and the high levels. So, but you also need to make sure that you're looking in specific guideline sections for any definition changes for any of the subsets of the codes. All right, so for the low-level medical decision-making, so already existing are the number and complexity of problems, which are 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. The following 2 are being added. So you'll have 1 stable or acute illness, or 1 acute uncomplicated illness or injury requiring hospital or observation level of care. And you can see that that's made to, so you can include those services. All right, and then for the high level of medical decision-making, it's really in the example section, there's 1 revision and one addition. So the examples of the, like the drug therapy requiring intensive monitoring, those are remaining. It's just the revision to the decision regarding hospitalization or escalation of hospital level care is being added. And then also the addition is your parenteral controlled substances. So the last hint of the day for those taking the quiz, you might want to remember parenteral controlled substances. And so with the expansion to the MDM table, it allows you to use that across all of the sections and subsections. All right, so expect a lot of green text in the E&M guidelines section because that indicates a change from the previous book. And so the previous guidelines overview will have to have updated definitions, and then it'll be shorter because they won't need 2 sets. And so in this part for the guidelines, they have sections that are common to all E&M categories and sections that are category specific. Most of the categories and many of the subcategories of service have special guidelines or instructions unique to that category or subcategory. Where these are indicated, for example, your hospital inpatient and observation care, special instructions are presented before the listing of the specific E&M service codes. And so CPT is pointing out that it's important to review the instructions for each category or subcategory. And the one nice thing that they have started, and I wish my mouse would start helping me out, is I wanted to, let's use this. The main purpose of the documentation, and this sentence here. So these guidelines do not establish documentation requirements or standards of care. The main purpose is to support the patient care. So those are, so those are the important parts that I wanted to point out. So just, it's not for documentation requirements. All right, and then of course, I try to turn off the annotation and get my page down was not wanting to work for me. All right, so kind of as an overview, the E&M section is going to be divided into broad categories like your office visits, your hospital or observation care, and then the categories are then further subdivided in like new or established, initial or subsequent. And then the basic format for the E&M code that's based on MDM or time is the unique code is listed, the place and or type of service specified, the content and the time. And the place of service and the service type is defined as where the face-to-face encounter occurs. An example of this would be a nursing facility resident. When the nursing facility resident is brought to the physician's office, then the place of service is reported as the office, or you use an office visit. Now, if the physician were to go to the nursing facility, then you would report the nursing facility service. All right, and so the new versus established really hasn't changed at all. And so the new patient has not received professional services from the physician or QHP or another physician or QHP in the exact same specialty and subspecialty who belongs to the same group practice for the past 3 years. And if a provider's on call, the patient's encounter is classified as if the unavailable physician or QHP provided the visit. And CPT says that when QHPs are working with physicians, they're considered as working in the exact same specialty and subspecialty. And the new versus established does not apply to emergency department visits because of the intensity of services, and it doesn't really matter if they're new or established. And then in the CPT book, there is a decision tree that helps determine the patient's status. So it kind of helps walk you through a little bit. All right, and now we are going to have some services that are initial and subsequent. For example, the the inpatient hospital and observation services. So the initial service is when the patient has not received any professional services from the physician or QHP of the exact same specialty or subspecialty in the same group practice during the inpatient observation or nursing facility admission and stay. So what this is, it's kind of similar to the new patient versus established patient, except that it's applying to that stay. So a subsequent service is reported when the patient has received the professional services during the stay. All right, so it can get a little crazy making, and we'll kind of go into that in a little bit. So, and again, with the same as the initial or new or established, it's if the provider's on call, that patient's encounter is classified as if that unavailable provider did the services, and it's for a single stay. So inpatient or observation services that transition to inpatient are considered a single stay, and a skilled nursing facility level of care that transitions to a nursing facility level of care is also considered a single stay for the CPT reporting purposes. All right. And now here we're going to get into some of the clarifications to some of the guidelines. And there has been some confusion when counting unique tests within the amount and or complexity of data to be reviewed and analyzed. And one important point is that you count each minute only once. So instead of being kind of double dipping, it's each minute only counts once. So if the doctor or the QHP orders a test or a study, does the interpretation, and then reports a separate code for the test or study, then you do not count that within the data to be reviewed or analyzed, because the provider is being paid for that review or analysis when they are doing the interpretation of that test or study. So an X-ray is an example. So if the patient's at an orthopedic clinic and the doctor orders an ankle X-ray and then does the written report, then the doctor can bill for the X-ray, but does not get to count that towards the data reviewed in that E&M visit. Now, let's say the patient is going to the emergency department and has that ankle X-ray, and the radiologist is going to read the X-ray and bill for the interpretation and report, but the emergency department physician may do a review of the X-ray and use the results in their analysis and the treatment of the patient. So in that case, the ED physician may use that review within the amount or complexity of data to be reviewed. So, so sometimes there can be a fine line. And then there are some tests that don't require separate interpretation. An easy example of that is some of the laboratory tests, because they have the levels and show with your, within normal limits or not. And those don't count as something requiring independent interpretation. And those may be counted toward the amount or complexity of data to be reviewed. So just wanted to point out that there is that document that is now documentation. And then also something that CPT wanted to put out there is for those, the E&M codes. I was trying to, okay. So this is another example. It's just, they include a medically appropriate history or physical when performed. And the nature and the extent of that history is determined by the treating physician or QHP. So the care team can collect information, and the patient or caregiver may supply information directly. And that can be either through the portal or questionnaire or just discussion. And that's reviewed by the reporting physician. And so the extent of the history and physical is not not an element. So just part of the newer guidelines but is really kind of the old. And so I just wanted to kind of go over that. So now there really are just 4 types of MDM: straightforward, low, moderate, and high. And the MDM is defined by 3 elements: the number and complexity of problems addressed, and the amount or complexity of the data to be reviewed and analyzed, and then the risk of complications and or morbidity or mortality of the patient. So this next slide is, well, it didn't link over like I wanted to when I did it. But here is that medical decision-making table, and I've condensed what CPT had published in the guidelines that they released early. And I've got a link to that area in my references section. And so I kind of just condensed it down so it fits on 2 pages, so that if you wanted to print it off, you know, and have it double-sided kind of as a little cheat sheet, you can. And so really the only differences are the number and complexity of problems to be addressed under the low category, and then the high. They have the examples here. So here we see the drug therapy requiring intensive monitoring for toxicity. And then here's where we see that revision for the decision regarding hospitalization or escalation of hospital care, and then the parenteral controlled substances. So there will be a link for this if you would like to have it. All right, and let me make sure I'm clicking on the, okay, resuming my slideshow. All right, so, and there are many guidelines in the office visit guidelines that are going to be the same for all of the E&M codes that involve the medical decision-making. And some of those are like the language for the number and complexity of problems addressed. And so I didn't bring all of them in. And so I just wanted to bring in the ones where there were changes. So the minimal problem has been updated just a little bit to add the 99281 to it. So emergency department visits are going to be in part 2, and for the 99211 and the 99281, you'd still need to meet the incident 2 requirements. All right, now there is already a definition for an acute uncomplicated illness or injury. And now there's going to be a new one that is an acute uncomplicated illness or injury requiring hospital, inpatient, or observation level of care. And so this one is just for a recent or new short-term problem with low risk of morbidity for which treatment's required. There's little to no risk of mortality with treatment, and a full recovery without functional impairment is expected. The treatment requiring is delivered in a hospital, inpatient, or observation level of setting. So when we'll take a look and we'll see where they've just revised some of the descriptions just to get that hospital level of care in there. All right, and so here we've got a new one for a stable acute illness. It's a problem that's new or recent for which treatment has been initiated. The patient's improved, and while resolution may not be complete, the patient's stable with respect to that specific condition. All right, so here's where we start to see some of the differences. So your chronic illness with exacerbation, progression, or side effects of treatment, basically they took off the part that says that does not require consideration of hospital level of care, meaning that in 2023, it can take that into consideration for that. So, and again, the 2022 definition for the chronic illness with severe exacerbation, progression, or side effects of a treatment. They're taking out, and it may require hospital level of care, and changing that so it may require an escalation in the level of care. So whether that's in the hospital or not, it doesn't matter. And then, yeah, so here's for the acute or chronic illness or injury that poses a threat to life or bodily function. I just kind of highlighted in yellow the part that is new. So this is staying the same. So what they're saying is that some symptoms may represent a condition that's significantly probable and poses a potential threat to life or bodily function. And these may be included in this category when the evaluation and treatment are consistent with that degree of potential severity. So that's where your documentation comes in important. All right, now in the amount and or complexity of data to be reviewed and analyzed, there's an update to the independent historian, or well, when the AMA did their webinar on the E&M code changes, they wanted to stress this part, is that a translator is not an independent historian. The translator is merely relaying the information from the patient, and they're not relaying, the patient's personal history. Sometimes that'll be difficult to translate when you have a family member who's doing the translation services. So it would be important to note what is being provided as an independent historian giving the history of that patient versus being translation services. So that's something you might need to watch out for. So just remember, the independent historian must be providing the patient's history and not just be relaying information. All right, and then the independent interpretation has been updated a little bit. So it's the interpretation of a test for which there is a CPT code, and an interpretation or a report is customary. This does not apply when the physician or QHP who reports the E&M service is reporting or has previously reported the test. So, and a form of interpretation should be documented, but does not need to conform to the usual standards of a complete report for the test. So just a slight update there. Okay. And then the drug therapy requiring intensive monitoring for toxicity. This is not the complete description because I couldn't get it to fit on my slide. And so it's just the part where they have the examples. And so what they're wanting to do is, an example may be monitoring for cytopenia in the use of an anti-neoplastic agent between dose cycles. So there has to be intensive requiring. So if it's something that you do, on an annual basis, like the monitoring the glucose level, that's not, or the annual electrolytes and renal function for a patient on a diuretic does not meet that frequency threshold. So they really haven't spelled out what constitutes that frequency, but it's just got to be something that's more than just on an annual basis. So I'm hoping that they'll be publishing something in the CPT Assistant to provide some guidance on that, because I don't like guessing. All right, so there are certain categories of time-based E&M codes that do not use medical decision-making, but they do use time, but they use time differently. And those are your critical care services. And so those are not affected by the changes. So it just, be sure to review the instructions for each category. And the emergency department services are not included in that move to the time-based services. And the time defined in the description is used for the code selection. and it requires a face-to-face encounter with the physician or QHP. So, all right, so the guidelines for selecting them is the time is the total time on the date of the encounter, and it includes both the face-to-face time and non-face-to-face time, doing those activities that require the physician or QHP, but it does not include the activities performed by clinical staff. And then also, it does not include any time spent in the performance of other separately reported services. And so I stuck the not separately reported, or the NSR here, so I can use the abbreviation on the next slide. And so those prolonged services are based on the total time on the date of the encounters that's spent caring for that patient. All right, and so these are pretty much the same as they are for the regular, the first office visit wave. So it's still the preparing to see the patient, obtaining or reviewing that separately obtained history. And so just remember, it's referring and communicating with other healthcare professionals that's not separately reported. So if you're doing any care coordination and your physician or QHP is also doing like the chronic care management or transitional care management, the time can count for one or the other, but not both. Just remember, it's no double dipping with the time. All right, and what's not included is any travel time, and then teaching that is general and not limited to a discussion that's required for the management of a specific patient. So in the list of what is covered is that if you're doing teaching or counseling with the patient or their caregiver, that's being used to specifically manage that patient. So what is not covered is if there's 10 patients come in to have a class on low back pain, that's not part of the E&M. All right. So now we get to move into the inpatient and observation codes, and this is really kind of a consolidation. And so it's so there are initial and subsequent. So we're not going to be using new and established. It's the initial and subsequent. So you can use these for hospital inpatient visits, hospital outpatient in observation status visits, and also for partial hospitalization psychiatric services. And observation status patients aren't necessarily located in an observation area. For example, if somebody's pregnant and needs observation, they may have that patient go up to the labor and delivery area. If the patient is having some coronary symptoms, they may go to the coronary care unit or intensive, well, they wouldn't be intensive care because then they would be inpatient, but so there's not necessarily one specific spot in the hospital that's called observation that would have all patients. So just be aware of that. And then there are some specific codes for when the patient is admitted and discharged on the same date. All right, so the total time on the date of the encounter, and that can be a continuous service that spans 2 dates, but is still going to be considered a single service. And you report that on one calendar date. Excuse me. So we'll have some examples of that. So anything that's continuous before and through midnight, all the time that's spent may be applied to the reported date of service. And so the observation codes are going to be merged or deleted and merged into the existing hospital care codes. All right, so some of the fun is going to come about with the initial versus subsequent. And so An initial service may be reported when the patient has not received any professional services from the physician or QHP, or another physician or QHP of the exact same specialty and subspecialty who belongs to that same group practice. So we've got this definition for us. And it's kind of similar to the new versus established, except it's related to that stay. And a transition from observation level to inpatient is not considered a new stay. All right. And so CPT is going to say that when a patient is admitted to the hospital in the course of an encounter at another site, so let's say the patient is at the clinic or the office, and then the doctor says, oh no, you need to go into observation status, head over to the hospital, I'll give them a call and they'll be able to get you right in. Okay, well, CPT is saying that the work within those two separate services can be so very different that you should be able to report both in like your office visit E&M code plus the admit. And CPT or CMS then is saying, nope, wrong. You can only report one E&M service per calendar date. So this will be helpful to then use those prolonged services if you need those. But this also causes confusion because then you have to know which, if you have a payer other than Medicare, which guidelines are they following? Which is the one where they have to pay the least amount of money. All right, and so I did not do a comparison view on these new codes because otherwise we'd have a million slides, and so I just went ahead and put the upcoming definitions. So your 99211. So here you've got your initial hospital inpatient or observation care per day for the evaluation. And so the 99221 is straightforward or low-level medical decision-making. And the time is 40 minutes must be met or exceeded. And so for your 99222, that is going to be your moderate level of medical decision-making. And that goes to 55 minutes. And then your 99223 is your high level of medical decision-making, and that's your 75 minutes being met or exceeded. And so these are for the initial codes. And then your subsequent codes, different time levels. So your 99231 is going to be straightforward or low level, and 25 minutes must be met or exceeded. Your 99232 is your moderate for 35 minutes, and then your 99233 is your high level and 50 minutes. So we have a doctor who sees a patient who's in observation status. It's moderate level of medical decision-making and spends 60 minutes in total time in the initial service. What CPT code would you use for that one? And that's all right. So for moderate level, that's the 99222, and 55 minutes is exceeded, but we're not up to the 75 minutes yet. So we'll take the 99222. All right. And then the second coding scenario was, how would you code that visit if the doctor's service began at 11:50 p.m. and lasted to 12:50 a.m.? Well, it would still be the same code because it's the same encounter, single visit. There we go. And let's say the patient is an inpatient and the doctor's done rounds today. And what would a low-level MDM visit be coded on inpatient day 3? So that would be a subsequent, and low level. So that's a 99231. And those are just kind of some easy ones. And so we can get moving some more. And so these two codes, your discharge day management, so rather than just being the hospital discharge day management, they are going to be used for the services for the inpatient or observation stays. And this should only be used by your physician or QHP who's responsible for the discharge. Any other providers should be using the subsequent hospital visit. So let's say your physician is the cardiologist and comes in and gives some post-discharge instructions, but the cardiologist is not responsible for the discharge. Then in that instance, the subsequent hospital visit would be used. And there's some more stuff that we'll get into when we go a few more slides. So here we've got the revised codes for your, again, for the discharge management, and it's your straightforward or low medical decision making, 45 minutes meta exceeded. The 99235 is your moderate with 70 minutes must be meta exceeded. And then your 99236 is your high level. And then you have your 85 minutes there. All right. Now for these services, the 99234 through 236, it's going to require 2 or more services. So one is going to be for the initial admission encounter and then one for the discharge. Now, here's where kind of some of the fun stuff comes into play, where CMS kind of causes some extra confusion. So if the admit and discharge is done during the initial encounter, report the initial 99221 through the 99223 codes. CMS has their 8 to 24 hour rule. And while they say, and so this is a longstanding rule out there where, you know, depending on how long the patient's there, whether it's considered, you know, one stay or if it's prolonged. So if the stay is less than 8 hours, then use the 99221 through the 99223. So let's say and then if you go over the 8 hours and you're still discharged on the same calendar date, then you can use the discharge day management codes, those 99234 through the 99236. So one of the kind of little tips that CMS did in the CMS, the final rule, the physician final rule, table 22 kind of gives a summary of the policy. So if they have less than 8 hour stay, discharged on the same calendar date as the admission or start of observation, then you should bill the initial hospital services codes only. And then for all of these, you can use the prolonged services if you hit that time frame. So if they've been in the hospital for 8 or more hours and it's the same calendar date, then you use the same day admission and discharge. So the 99234 through the 99236. So, and then, excuse me. So if you have less than 8 hours, the different calendar date, then you use the initial hospital services only. And then if it's over 8 hours or more, and there's a different calendar date than the date of admission or start of observation, then you can do the initial hospital services plus the discharge day management service. And so I did, the link to the final rule is in the references. So you'll have that handy. All right. Okay, now to kind of go a little bit farther. This is regarding your consultations. And so if you have a consultation, excuse me, if you have a consultation that is performed in anticipation of or related to an admission by another physician, and then the same consultant performs an encounter once the patient's admitted to the hospital, for those, you're going to report subsequent care codes. And so that instruction applies whether the consultation occurred on the date of the admission or a date previous to the admission. And so it applies for consultations reported with any appropriate codes. So like if you have an office or other outpatient visit, or an office or other outpatient consultation. So this I made into a too long didn't read. So in the example, let's say your provider provides the consultation prior to the patient's admission, then the patient gets admitted. If that same consulting physician then is going to then report subsequent hospital codes during the patient stays, and any other ones. So instead of having the nice green wall of text, here's kind of some bullet points for you. All right, and then there are some revisions to the consultation codes, and in keeping with aligning with the medical decision-making codes, they did delete the 99251, and so here are the revised descriptions for the existing codes. So the inpatient or observation consultation for a new or established patient, straightforward medical decision-making, and then the total time is the 993 total time. I about gave you a procedure code. So it's 35 minutes. 99253 then is your low level, goes to 45 minutes. And I bet you guess where this is going. So the 99254 is moderate, 60 minutes. 99255 is high level and 80 minutes. And then just some pointers is the type of the E&M service provided at the request of another physician. QHP or appropriate source is a consultation, and it's to see if they recommend care for a specific condition or problem. And then the consulting physician or QHP may initiate diagnostic or therapeutic services at the same visit or even a subsequent visit. A consultation that's initiated by family members or the patient, but not requested by the physician or QHP, or another appropriate source, is not reported using consultation codes. And then also remember, the consultant's opinion and the services ordered must be communicated in, written report back to the requesting provider. And if the payer doesn't cover consultation codes, then other appropriate codes may be used. CPT said they anticipated CMS would not recognize these codes, and they were right. Okay, so prolonged services, most of these are going to be the ones that are reported on the date of the E&M service. So we've got the 99354 and the 99355, which is our prolonged services in the outpatient setting. Those are being deleted. And the replacement one was the 99417, which was effective back in last year. And so the 99356 and 99357 is being deleted. The replacement for the CPT is the 99418. Remember, that had the placeholder, the 993X0. So it can be added on next one. We'll touch bases on the 99358 and 59 in a few slides. All right, so this is just kind of how they're used. For me, the CPT guidance is fairly straightforward. Once you meet that, the time, that initial time past the time of the primary E&M code, you can start reporting prolonged services. Just remember that time spent performing separately reported services is not counted. And so the 99418 can be used to report the prolonged total time provided on the date, and that is the time with and without direct patient contact. So, the 99358 and 59 is used when a prolonged service is provided on a date other than the date of your face-to-face E&M. And it's not dependent on the time being used to select the face-to-face service. And so then here's some directions from the CPT manual. This prolonged service without direct patient contact may only be reported when it occurs on a date other than the date of the evaluation and management service. And they gave some examples. An extensive record review may relate to a previous E&M service performed at an earlier date, but it must relate to a service or a patient where there was face-to-face patient care has occurred or will occur and relate to ongoing patient management. And there's an extensive list of do not reports, and it's like the different care management codes and those types of things. So now it's not always easy, especially when CMS gets involved and says they don't agree with how CPT is doing things. So, you know, how they have for the office visits, CMS said, well, we don't agree with you and we think there should be a 15-minute gap. Well, they have done the same thing with these. And so when CMS published the proposed rule, they had a placeholder for some G codes, and now they have published them. I did highlight the 99418 because in the final rule, they still had the placeholder, the 993XO. So I've just updated that in here. So you've got your prolonged hospital or inpatient or observation care, E&M service beyond the total time for the primary service. So list separately in addition to the 99, and it gives you there, and do not report the G0316 on the same date of other prolonged services for E&M. And then do not report for any time unit less than 15 minutes. So this is for the inpatient or observation care evaluation and management. They had the GXXX2, which is now going to be the G0317. And this is for your nursing facility evaluation and management. And so they give you the list there. The list goes on. And then they have one more. The G0318 is replacing the GXXX3. And this is for your home or residence evaluation and management services. Again, for those, and gives you the codes that you should report it with and those that you should not report it with. All right, so the CPT 99223 time period is 75 minutes through 89 minutes, and prolonged services time can start at minute 90. CMS says, nope. They say that 99223 lasts until minute 90, and then there's a 15-minute gap. So then prolonged services can start at that 105 minutes, and you would report with that with the G0316. All right, and then the time spent for code selection may expand beyond services on the date of service. And so don't report the 99358 or the 99359 with the G0316. And so what I did was listed the CPT code and the HCPCS code and just kind of put the time that they must meet or exceed. And so for the 99221 must meet or exceed, you can start reporting for those that follow AMA CPT guidance. You can use the 99418 at 90 minutes and your G0316 at 105 minutes. Okay, And so kind of the same thing, similar with those inpatient or observation care. These are the subsequent care code times. And then also with your discharge day management. So now when you get to the consultation codes, CPT has the 99418 that can be used. CMS did not provide a code because they don't cover the consultation codes. All right, and then when you get into the other services, I think I've entered the twilight zone because CMS has kind of taken some liberty with some of the information that was used when the AMA was trying to evaluate, value the codes. The AMA took some different time frames specifically for those, the initial visit, the initial nursing facility visit, and the admit discharge same day services. And so CMS has applied those to these prolonged time codes. And so for the initial and subsequent inpatient or observation services, you can use the G0316 starting at 105 minutes, and you just count the time spent on the day of the visit. Now, when you get to the admit and discharge management for the same visit, you still use the G0316. You have to hit that 125-minute threshold, but you can count the day of the visit and up to 3 days after. Just because they're CMS and they can mess with you that that way. And so your initial nursing facility visit, you've got your G0317 and 995 minutes. But for this one, you can count the day before, the day of the nursing facility visit, and up to 3 days after. And what that will allow for capturing of instances where there might be a really intensive or extensive review of medical records that needs to be done, some coordination of care that needs to be done. And that might happen, because sometimes it takes a while for that bed to open up. And so it just allows the provider to record their time within that time frame. So for the nursing facility visit, the 99306, it's the day before, the day of, and up to 3 days after. And when you get to the same for the subsequent visit, you have the day before, the day of, and up to 3 days after. It's when you get into the home residence where they've kind of gone off their rocker, and you can do 3 days before, the day of, and up to 7 days after. And so it's a little bit complicated, and I think I would have to have a decision tree, and that is probably going to require some training if your provider does those types of visits. So it does allow for reporting of services that maybe you weren't able to capture before, but it is it's not an easy concept to get. So that's why it's kind of the twilight zone. And so we did kind of get to the end, and I think we're right at the end, and I apologize for that. And here are the references.
Awesome. Thanks so much, Artis. That was great. Like we said, we are out of time, but we will make sure to answer all of those questions for you. And there are a lot, so it might take a little bit longer than normal to get them answered, but once they are, they'll be posted to our website, same place that you registered, so you can find those there. And another reminder, we have a webinar tomorrow, and we also have a lot coming up. So you can just find those on our website and register for those there. They're all posted for the year-end sessions. And we will send the email with the recording link, presentation link, the extra chart that Artis mentioned, and the CU certificates by end of day tomorrow. If you don't receive them, go ahead and just reach out to us and we'll make sure that you get those. Thank you very much for joining us today. I'm sure we will see some of you tomorrow. Thanks, everyone.
Thank you. Bye.